Okay, so today I would be talking about dental composites. Let us see what dental composites are. Dental composites. Okay, let us see what dental composites are. See, dental composites are basically resin based materials, synthetic restorations, which are one of the most conspicuous and the operatives used in the modern restorative dentistry. So it was basically in the year 1962 that Dr. R.L. Bowen, he introduced first dental composite. First dental composite. Mm. These dental composites basically consist of three principal phases. One is the matrix or the continuous phase. Okay. And when it is an organic matrix or a continuous phase, which is made up of resin monomers, it requires certain fillers to enhance its mechanical and physical properties, as well as make them more aesthetic as compared to unfilled resins. So it is a continuous phase that is an organic component of dental composites. And the filler particles, they form the inorganic component of the dental composites. Sorry everyone for the technical snag. There was a lost connection. So we are starting with dental composites basically. Okay. So today I would be talking about dental composites. They are one of the chief restorative materials used today. It was in the year 1962 that Dr. R.L. Bowen he introduced the first dental composite material. He introduced the first composite. And these dental composites, they are synthetic restorative materials based on resins. So they consist of three principal phases. Okay. One is the matrix, that is the organic matrix principally. And this matrix is also called the continuous phase. It is called continuous phase. Then we have to enhance the properties of the matrix, we have filler particles. These filler particles are mostly inorganic filler particles added to the composites. They form the dispersed phase. Something is added to the matrix. So it is called dispersed phase. And we know that these are two technically different materials, inherently different. One is an organic matrix, which is made up of resin monomers, to which we are adding certain inorganic particles called fillers. So, inorganic fillers have to bond with the matrix of organic resins to form a composite material. So, we require some sort of a coupling agent, something that bonds the filler particles to the matrix. So, these are the three principal constituents of the modern dental composites. Apart from them, there are certain accessory ingredients. We'll see them one by one. Firstly, talk about the matrix. What does the matrix consist of? It is basically made up of resin monomer. What are the resin monomers? These are methacrylate resins like bis-GMA and PEG-DMA. MA stands for methacrylate. These are resin monomers usually present in the concentration of 50% by weight to 50% by weight. That is 1 is to 1. This bis-GMA is a high viscosity material. Eta is the standard symbol for viscosity. Similarly, PEG-DMA is a low viscosity material. When we combine these two resin monomers, we get the organic matrix of the resin composites. These resin monomers, they are held by van der Waals forces. In the uncured or unset composite that we procure as a restorative material, there are resin monomers principally made up of methacrylate resins like this GMA and TEG-DMA, and they are held together by van der Waals forces. Whenever we would cure them, okay, there are different modes of curing the resin composites. Like the most common restorative materials are the light cured resin composites. We also have self cured or chemically cured resin composites. There can be heat cured and microwave cured resin composites also. Okay, so curing is basically means that we polymerize them by any of the method like light, heat, or self curing by chemicals. This causes resin monomers to convert into resin polymers and the composite hardens, but it sets. So, whenever there is polymerization from the resin monomers to the resin polymers, the bonding pattern changes from van der Waals forces to covalent bond. So the molecules in the polymers, they are held together by stronger forces which are called covalent bond. Van der Waals forces are weak molecular attractions. They convert to covalent bond in the polymers. And when they convert to the polymer from van der Waals forces to covalent, there's a huge polymerization shrinkage. This polymerization shrinkage, you should always remember, is the principal disadvantage of resin-based restorative materials because they shrink upon polymerizing. So when they shrink upon polymerizing, they tend to pull themselves away from the tooth surface. So they create a lot of interfacial tension or stress that can result to debonding of the composite from the tooth. Or if the shrinkage is excessive, it can even fracture the tooth. So whenever we talk about resin-based materials, the first thing that should come to your mind as a disadvantage is what? Polymerization shrinkage. Okay. Now let us see what are the fillers present. These fillers are basically inorganic particles like colloidal silica, heavy metal glasses, heavy metal glasses like barium, zirconium, strontium, small particles, colloidal silica. Sometimes in the traditional composites, quartz particles have been added. So these are the inorganic particles which are added. Now, what is the need to add fillers to the organic materials? These fillers, they enhance the mechanical properties. Enhance the mechanical properties of your resin-based composites. They also increase the optical properties. We know that resin-based composites are one of the most aesthetically pleasing restorative materials, direct materials available. So these optical properties are enhanced by the fillers present in them. Okay, they decrease the polymerization shrinkage. Another advantage is thing that is given by fillers. They also decrease the water absorption. The organic matrix consisting of resins has a tendency to absorb moisture from the saliva or fluids present in the oral cavity, and due to absorption of moisture, they cause leaching of certain materials. There's unstable dimensions, and over time they become discolored and change in their dimensions. So to prevent all these things, fillers are added to them. They enhance the mechanical and the optical properties. They reduce the polymerization shrinkage and water absorption, and they also reduce the alpha. Unfilled resins have a very high alpha. What is the meaning of alpha? Alpha means coefficient of thermal expansion or contraction. So unfilled resins have a tendency to expand and contract with temperature changes too much as compared to the tooth structure. So in the long run, such restorations are not desirable. So to reduce the alpha, that is coefficient of thermal expansion or contraction, these are added. Fillers are added, so they make them more compatible with the tooth structure. Okay. Now we know that these fillers, they are inorganic. They are coated with a coupling agent. Ca stands for coupling agent. Okay. We need to bond the inorganic fillers with the organic matrix. So the fillers are coated with coupling agent, mostly present as a monomolecular layer. Is a monomolecular layer on the surface. So if this is a filler particle, we would apply a monomolecular layer of coupling agent that would be added to the matrix. So it forms a bond with the matrix. This is a filler. This is a matrix, and this is a coupling agent. Ca stands for coupling agent. Now, this filler particle is bonded to the coupling agent by a bond called siloxane bond. Siloxane bond. What is a siloxane bond? It consists of silica, oxygen, silica molecules. The mechanism of bonding of fillers with the coupling agent. Similarly, these coupling agents, they bond to the matrix by way of covalent bond. So there is a different mechanism for the coupling agents to be bonded with fillers on one side and with the matrix on the other side. That's why they are called coupling agents. Okay. These coupling agents, the most common ones, they are organosilanes. The most common example of a coupling agent is organosilanes. So these are compounds which are organosilanes. Okay. Then we talk about accessory components of resin-based composites. The three principal ingredients are the matrix phase, the fillers, and the coupling agent. Accessory components, they include activator initiator system. Activator initiator system. We need something to activate and initiate the polymerization of composites from monomers to polymers. So these activator initiator system, as I am talking about restorative composites, two principal modes of activation can be there. Chemically cured composites, okay, which are two paste systems. They are also called self-cured, chemically cured or self-cured. Then there are visible light cured. You must be knowing that majority of the restorative composites in the contemporary dental practice are visible light cured, we use blue light, which is part of the visible spectrum. So these two different composite materials which are used as restoratives, they have different activator and initiator systems. If we look about the chemically cured or the self-cured first, then they have initiator of polymerization. That is a compound called benzoyl peroxide. Okay. And they have an activator of polymerization. That is a tertiary amine. So these are two different chemicals present. There are two paste system. One paste would be having an activator, another paste would be having a initiator. So when we mix them together, the polymerization starts by way of these two chemicals, respectively, as initiator and activator. If we talk about visible light cured composites, light, light means photon of energy. So they have a photo initiator. They have a photo initiator, something which is initiated by light energy. Okay. This photoinitiator most commonly present in the composites is CQ, that is camphoroquinone. Camphoroquinone. And this camphoroquinone is a bright yellow compound which is present as a photoinitiator. And it is basically a weak photoinitiator, so it requires a secondary electron donor. I am talking about the initiator present in visible light cured composites. It is principally camphoroquinone with some secondary electron donor, which is also an amine. Okay. So, if we talk about the activator, what could be the activator over here? Blue light. When we show blue light to such composites, they start initiate polymerization. So, this blue light is absorbed by camphoroquinone, which is the photoinitiator present in the composites. Now, this blue light is in the region of 400 to 500 nanometer. The wavelength of blue light is this. And this camphoroquinone absorbs maximum 474 nanometer light, which is again falls in the blue region of the visible spectrum. That is the reason we use only blue light to cure the composites. If you talk about the visible spectrum, it consists of 7 colors from violet to red with cure. But only blue light is used because it is the light that is absorbed by the photoinitiator present in the. So these are activator and initiator systems for the self-cured and light-cured composites basically. Then the other accessory component that is present is inhibitor of polymerization. Especially if we talk about the light-cured composites. See, visible light is present in the ambient atmosphere. It is present in the clinical setup. It is present in the operatory light. So with this visible light can initiate the polymerization of the composite during storage or during accidental exposure to the light. So to prevent the polymerization of composites during storage or when it is not being used as a restorative material, BHT is added as an inhibitor of polymerization. What is BHT? It stands for butylated hydroxytoluene. Stands for butylated hydroxytoluene. Okay. It is present in a low concentration of 0.01% by weight, BHT. And then finally we have got optical modifiers. You know that dental composites are highly aesthetic restorative material. And have you ever thought that when the basic composition of all the composite remains the same, like they would be having the same matrix, the same fillers, the same coupling agents, and the same activator and initiator system, how they are available in different shades? They are available in different shades because of the optical modifiers like various metallic oxides present in low concentration of 0.001 to 0.007% by weight. Such low concentration of different metallic oxides like aluminum oxide, zirconium oxide, tin oxide, they are added to give different shades to the composites like A1, A2, A3, B1, B2, B3, etc. etc. Okay, this is the composition of dental composites, the modern composites. Now let us see how do we classify the various composites. Or we talk about the classification. See, there are two principal schemes for the classification of composites. One is a traditional method that is based upon the type of filler. You know that the organic matrix would be either this GMA or tag DMA or a combination of them. Mostly the methacrylate resins in the traditional composites are present, but there is variation in the type of filler. Second scheme, which is more commonly used in nowadays, is based upon the size of filler particles. Type of filler and size of filler particles. To simplify the procedure, based upon the type of fillers, four principal composites are present conventionally. The first ones, they are called traditional composites. Traditional composites. Traditional composites, they contain quartz filler particles which are quite large, 8 to 12 micron in size. Large particles of quartz are present in these composites. Although they are not marketed in the current scenario, they have become almost obsolete. But for your academic purpose, you should know what are traditional or conventional composites. They consist of quartz as filler particles, 8 to 12 micron in size. And if we talk about the filler loading, what is meant by filler loading? How much amount of filler is present in a particular amount of composite is known as filler loading. It is in the range of 70 to 80% by weight. Okay. Then we have small particle filled composite. Small particle fill means they would be having heavy metal classes. What type of filler are present in them? They are the heavy metal classes like barium, strontium, zirconium. But these particles are quite small, 0.5 to 3 micron in size. That's why they are called small particle filled composites. If we talk about the filler loading of these composites, okay, the filler loading for these composites is quite high. It is in the range of, I would say, it is one of the highest filler loadings amongst the conventional composites. It is in the range of 80 to 90% by weight. Then the third type of composites, based upon the type of fillers, they are called microfilled composites. Microfilled composites. What type of fillers they contain? They consist of colloidal silica particles, which are very small, 0.04 to to 0.4 micron in size, colloidal silica particles. And as you can see, because of the very small filler particle size, they have one of the lowest filler loading. Why the lowest filler loading? Because of the extremely small size of the filler particles, they have an increased surface area in total. And because of that high surface area, only a small amount of filler can be added to a particular amount of resin, coat them completely. You understand? The surface area becomes very high of these small particles, the collective surface area we are talking about. So the filler loading is only in the range of 50% by weight. Okay. And what happens because of the poor filler loading? They are used for low stress situations. Which type of composites? The microfill composites. And I hope you all must be knowing what are low stress situations. Low stress situations are basically class 3 and 5 situations, restorative conditions, and small class 1 restorations. They are all considered to be low stress situations. Okay. A typical indication for microfill composites are cases of idiopathic erosion. Cases of idiopathic erosion. These cases of idiopathic erosion are also called abfraction. Abfraction lesions. These are a type of non-carious cervical lesions. These are a type of non-carious cervical lesions, means lesions which are present in the cervical area of the teeth but not due to caries are idiopathic erosion or abfraction. One of the type of non-carious cervical lesions. What happens if this is a tooth that is having heavy eccentric occlusal forces? Okay, the patient is having heavy eccentric occlusal forces. The occlusion is not balanced. Then these forces, they are transmitted and concentrated into the cervical area. There is enamel microfracture and development of lesions which are called abfraction lesions. So what is the etiology for abfraction lesions? They are non-carious cervical lesions which develop due to heavy eccentric occlusal forces. And what happens because of this? There is chipping of structure at the cervical region. For such conditions, we require composites called microfilled composites. So one of the unique indications for microfilled composites is abfraction or idiopathic erosion lesions. If I come back to the classification, the fourth type, according to the type of fillers, would be hybrid composites. Hybrid composites. Hybrid composites consist, as the name indicates, two type of filler particles. 20 to 30% of the filler particles, they are colloidal silica, which is present in microfilled composites, and remaining, okay, means 70 to 80% of the fillers, they are heavy metal classes. So as the name indicates, hybrid, they consist of two type of filler particles, the colloidal silica and heavy metal classes. So if we talk about the filler loading, it is intermediate of the microfilled and the small particle filled. Means it would be more than microfilled but less than small particle filled in the range of 75 to 85% by weight. And if you could see, I have given the figures for the filler loading in percentage by weight. At times, you can encounter questions where they are asking you filler loading for a type of composite in percentage by volume. So instead of remembering separate data, you should remember the conversion, that is 75% by weight is equal to 50% by volume. So you just remember it by weight, and according to the question, you can convert it on an average basis according to the volume percentage. So these are the four types of composites. The regular composites, which have been classified based upon the type of filler particles. If we look at the more contemporary classification that is based upon size of fillers, they can be classified as mega-filled, macro-filled composites, midi-filled composites, mini-filled composites, micro-filled composites, and nano-filled composites. If we look at the size, mega-filled are quite large, more than 100 micron in size. Macrofilled are in the range of 10 to 100 microns. Midi-filled are 1 to 10 micron in size. Mini-filled are zero point 0.1 to 1 micron in size. Microfilled are further smaller, 0.01 to zero point 0.1 micron in size. And the smallest type of fillers are the nanofillers, 0.001 to 0.01 microns. Sometimes this is 0.005 to 0.02 microns in size. Any of the figures would be representing nanofilled composites. So a more contemporary scheme for classification of composites is based upon the size of the filler particles and not the type. So these were your regular composites which are used. Now we talk about polymerization of composites. For polymerization, as we have already seen that the majority of the dental composites are visible light cured. So for polymerization, we use curing lights, which are the activators. So you have manipulated the composite according to the restorative need in the patient's mouth. Now you want to set it. You have to activate the polymerization. So that polymerization is activated by blue light. So whenever we show blue light, there is activation, then there is initiation, then there is progression, and finally there is termination of polymerization. This is the sequence of steps that takes place when you show blue light to a composite resin. It goes through first step activation, then initiation, progression, and finally termination. And if we have to classify the type of polymerization, it is an example of addition polymerization. So the composites undergo what type of polymerization? The addition polymerization. Okay. Now we talk about the curing lights. The first and the most conventional lights, they are the QTH bulbs. QTH stands for quartz, tungsten, halogen. So basically, they are gun-like devices. Okay, like this. They consist of a quartz bulb into which there is a tungsten filament There's a bulb of quartz with a tungsten filament, and the bulb is filled with halogen light. When current is passed through them, they emit electromagnetic radiation. What type of radiation is emitted? Ultraviolet, visible, and infrared. They emit all type of radiations. And what is the radiation that we require for curing of composite? We need only the blue region of the visible spectrum. We do not require ultraviolet and infrared. And as you know, whenever infrared radiations are there, there would be heat generation. So when current is passed through quartz tungsten halogen unit, there would be heat generation. To dissipate the heat, there is a cooling fan at the back of the unit to keep it cool. And it is emitting all sort of radiations, so we require certain filters. What filters? The ultraviolet and infrared band pass filters. They would remove the unnecessary ultraviolet and infrared light, and only the blue light is emitted from this light guide. This is a fiber optic tip that is used to focus the light onto the tooth surface. Okay. Sorry. This is the basic configuration of a QTH bulb. These QTH bulbs, they have got very low efficiency because we can see that majority of the light that is generated is into the 3 spectrum, and we require the blue light only. So very less efficiently, there's loss of light in different spectrum. There's loss of energy through heat generation. So their efficiency is less than 0.5%, and they have low surface life. Low service life of nearly 50 hours. The QTH. The second type of curing lights, they are LED lights. LED lights, they are the most common. Okay, they are very ergonomic. Ergonomic means they are lightweight. They are just like pencil or a pen. Such small dimensions are available for the lights, and they can be used conveniently. They are battery operated. Being battery operated, these lights are very portable, handy, easy to use. They emit only blue light, which is the useful light that we need for the curing of composites. So there is no heat generation, so they do not require a cooling fan. Similarly, they do not require any filters because whatever light we are getting is the useful blue light. These LED lights, they have got 3 generations of LED lights. 3 generations of LED lights are there. Okay, technically called first generation of LED lights, second and the third generation of LED lights. What does the generation means? The first generation, they had a low intensity blue light that was not very useful for the successful curing of composites. The second generation, they have high intensity blue light. They are the lights which are currently used. The most common type of LED lights, they are the second generation. Okay, they emit high intensity blue light that cures the composites very well. Then there are certain third generation LED lights. Third generation, they emit both blue light and UV light. So because they emit not only the blue, but some UV light also, they are called polywave or multi-wave LEDs. Okay. They are emitting more than one color of light. And what is the need of ultraviolet light? Because certain photoinitiators, certain photoinitiators, they require ultraviolet light for curing. Which is the most common photoinitiator? Camphorocyanone. It requires only the blue light because its maximum absorption is at 474 nanometers. But certain photoinitiators, example, ivosirin, they require what? Ultraviolet light. So some of the composites which are specifically manufactured with a different type of photoinitiators like ivosirin, they require some component of ultraviolet light along with blue light. That's why for curing of such composites, we require third generation of LED lights. But for the regular composites, which is the most common type of LED light, the second generation that emits the high intensity blue light. If we look at the third type of curing lights, they are plasma arc light. As the name indicates, plasma arc light, they are emitted through xenon gas. When current is passed through a filament placed in a xenon gas chamber, it emits high intensity white light. Not the blue, but the white light. Okay, this is known as plasma arc light. Because it is a high intensity white light, we require to filter out all the other six colors except blue, so it requires certain filters to get the useful blue light. Okay. And it causes rapid curing of composites. Because of the high intensity of light, higher as compared to LEDs and QTH, they cause very rapid curing of composites. But remember, very rapid curing of composites is not always advantageous. Okay, so we require gradual curing of composites that is most relevant clinically, more desirable clinically as compared to rapid curing of composites. Another disadvantage I would say for these lights is they are not portable. Because they are not battery operated, they are not portable. Okay. The fourth type of lights, they are the laser lights. Laser means high intensity, single wavelength of light is emitted. High intensity single wavelength of light. That high intensity single wavelength of light is emitted through argon laser, which emits only 490 nanometer. 490 nanometer again would be blue light, high intensity blue light. So it causes most rapid curing of composite. It can polymerize composite in nearly 5 seconds. But that is not a desirable situation. Okay, that's why they are not commonly used. The most commonly used ones are the second generation of LEDs. Now, after the curing lights, we'll talk about the curing variables. Curing variables means what all factors need to be considered for the key clinical polymerization of visible light cured composites. Firstly, minimum intensity of light required for the successful curing of composites is 300 milliwatt per square centimeters. Sometimes it is represented in joules. So it would come out to 16 joules per square centimeters. For successful in vivo curing of composites, this is the minimum intensity that is required. We always place composites in increments. Why incremental placement is done? Like dental amalgam, we do incremental placement to allow sufficient light penetration and relaxation of polymerization stress. In the beginning only, I have told you that whenever we talk about composites, the most significant disadvantage would be that they undergo massive polymerization shrinkage. So we have to incorporate certain means in the clinical procedure so that that polymerization shrinkage can be minimized. So we place incremental curing. Incremental curing is done in increments of 1.5 to 2 millimeter thick increments. Now, if you are doing a large restoration, a large class 2 restoration, or a large restoration in a tooth, then this incremental curing of composites can be tedious. It requires multiple increments to be placed. It can be tedious, it can be technique sensitive because we have to maintain isolation for the longer period. Okay. To circumvent these disadvantages, some modern bulk fill composites are available. What is the meaning of bulk fill composites? We can build up the restoration in increments as thick as 4 to 6 millimeter, more than twice of what is done with conventional composites. Why? They can be placed in such thickness because they allow better light penetration. Now, what is done with these composites so that the light penetrates deeper? Chemistry remains the same type of fillers are there, same type of base materials metrics are there. But what is done? They have increased filler size but decreased filler loading. These two fundamental changes are done. You know that filler particles, they are inorganic particles that cause reflection and reflection of light. So whenever the number of filler particles is reduced but their size is increased, larger surface area is available for the light to penetrate deeper by way of internal reflection and refraction. Okay, so these are the two changes which are done with bulk fill composites. Example of a bulk fill composite is SDR, that stands for Smart Dentine Replacement. Third thing that we consider about the curing variables is known as degree of conversion. We know that we are polymerizing monomers. So degree of conversion basically stands for percentage of carbon-carbon double bonds which are present in monomers that change to carbon-carbon single bonds in polymers. This is known as degree of conversion. How many carbon-carbon double bonds in the monomer chain would change to polymers single bonds? Usually composites have a degree of conversion in the range of 40 to 65%. 100% conversion never occurs. This is the average degree of conversion for the composites. Now this degree of conversion is related to percentage of carbon bonds in monomers that changes to single bonds in polymers. Okay. If we talk about self-cured composites, they have a greater degree of conversion. Restorative composites can be either chemically cured or self-cured or light cured composites. So self-cured composites have a greater degree of conversion as compared to light cured composites. Okay. Similarly, at 10 to 20% degree of conversion, whenever we are curing the composite at 10 to 20% degree of conversion, there occurs gel point. Gel point means it is the stage in the polymerization of composite at which the composite begins to harden. Initially, it is quite soft and manipulable, and then it begins to harden. That is known as gel point. It occurs at 10 to 20% degree of conversion. Then another variable is the light tip should be held within 1 to 1.5 millimeter of the surface. And perpendicular to it. Maximum curing occurs when the light tip, if this is the curing composite surface being cured, and this is the light tip or the light guide, it should be placed at a distance of 1 to 1.5 millimeter without touching the surface. When we show light, almost perpendicular 90 degrees, maximum curing occurs. So it is always advised to keep the light tip oriented perpendicular to the surface for maximum curing. And this light penetrates and it gives a segment of composite cured like this. Maximum curing is at the surface and the curing decreases as we go down. That's why incremental curing of composites, especially the light cure composites, is done to allow sufficient penetration of light and adequate polymerization from monomer to polymer. Okay. Next factor related to curing of composites is that light shades, they require lesser curing time. Darker shades require greater curing time. Okay. And then, depending upon the different restorative conditions, we have an important clinical factor that is called configuration factor. This is related to the curing of composites. It basically represents the ratio of bonded surfaces to non-bonded surfaces. Ratio of bonded to non-bonded surfaces. This C factor was initially proposed by Charles Davidson and Fields. Okay. Bonded means what all surfaces the composite is bonded to the tooth structure. Non-bonded surfaces means the composite is free from the tooth structure. Like if I talk about a restorative situation like this, here we place the composite. And if these are 1, 2, 3, and 4 surfaces, then this is a non-bonded surface, and these 3 are bonded surfaces where they are coming in contact with the tooth. And higher the configuration factor means greater the number of bonded surfaces, greater would be the polymerization stress on the composite. A composite that is coming in contact with the tooth structure more has a greater configuration factor. It would shrink more and try to pull away from the tooth structure. Okay, so there can be different classes of cavities, like class 1, 2, 3, 4, and 5. Traditional GV Black classification into class 1 through 4, and Simon added class 5 to it. Sorry, class 1 through 5 by GV Black and class 6 by the Simon. So whenever we encounter such clinical situations and we have to talk about the configuration factor, it can be simply got by writing 5, 4, 3, 2, 1 divided by 1, 2, 3, 4, and 5. So what are the respective configuration factors for these situations? 5, 4 by 2 is 2, 3 by 3 is 1, 2 by 4 is 0.5, and 5 by 1 by 5 is 0.2. These are the respective values of C factors for these clinical situations. Very simply, you can remember and answer like this. Whenever C factor is greater than 3, it means high polymerization stress. So what is the situation where you'll find the maximum polymerization stress? In a class 1 restorative situation. So a class 1 restoration with composite may look simple to do, but clinically, because of C factor associated with it, we have to be very meticulous in the building up of restoration so that minimize polymerization shrinkage and minimum post-operative sensitivity is there. This is the C factor related to the polymerization of composites. Now, all these have been the traditional composites, and we have talked about the polymerization shrinkage. There can be some newer advances in composites. Some newer composites. They are basically flowable composites. Okay. Packable composites. We have seen the classification based upon the type of fillers and the type of filler and the size of filler particles. Apart from that, there are some unique modifications in the composites. Low shrinkage composites. Flowable, as the name indicates, they are very less viscous or they are fluid enough, so they have got low filler content. What is the use of such flowable composites? As a first layer on tooth structure below regular composites. They're used as a first layer so that they flow and adapt very well to the tooth structure. Packable composites, as the name indicates, they are condensable, like amalgam. Whenever we are doing restorations, especially class 2 with composites, development of strong proximal contacts is a clinical challenge because composites are soft, they cannot be condensed, so development of a good proximal contact is a challenge. To counteract that, there are certain condensable composites or packable composites which are based upon fibrous filler particles. Fibrous fillers are there. The fillers are in the form of fibers that orient themselves and allow sufficient pressure of condensation to be placed. Then we have low shrinkage composites. We have seen that polymerization shrinkage is the chief disadvantage of composite. To counteract that, they have altered chemistry. Altered chemistry means they would undergo ring opening polymerization. Additionally, what is the polymerization method? It is the addition polymerization. They keep on adding chains. Ring opening polymerization means they are monomers like rings. When they are polymerized, they become chains. From ring in the monomers, they become chains in the polymers. This is known as ring opening polymerization. So they have altered chemistry. And this ring opening mechanism reduces the polymerization shrinkage, the principal disadvantage of composite. Okay. This is all about the basics of dental composites, starting from their classification, composition, and their light polymerization variables. This is all for today's session of Dental Composites. I'll see you next time with some other interesting topic related to the subject of cons and endo. Till then, keep reading. Goodbye from my side. Good night, everyone. Thank you so much for being connected with me. Thank you.